Okay, so we kind of talk about geriatrics kind of throughout the entire course. I feel like, anytime we're talking about older patients, like we just know they tend to be more likely to be susceptible to a lot of these side effects and a lot of these different aspects of the medication. I'll talk about some specific examples here. I know Professor Lack has gone over this with you as well, so I'm not going to get like into super nitty gritty details, but a lot of the concepts here are what I'm going to be kind of focusing on, and different little kind of pitfalls you want to be careful of with your geriatric patients here. I also include some formal stuff on the prescription writing. I know you guys are already experts at it, and in fact, I'm going to find that out as soon as I get to grading your guys' prescription assignments, which are forthcoming. Just wait. I know I'm a little bit slow on these, but again, there's 63 of you, and there's 3 apiece, so there's quite a few of those to check. Anywho, so right. So when we're dealing with our geriatric patients, right, who do we consider to be geriatric? Right, 65 or older, right? They only say age is just a number, right? It's only you're only as old as you feel, right? Approximately 80 currently. Like a 65-year-old man's disposition with like a 13-year-old's like maturity level, so somewhere it equals out to around 32-ish. Currently, but anywho, right. So we know we're getting older and older patients all the time. Like we have an aging patient population here. Even us millennials are going to start to be aging out here pretty soon. It feels like, right? Every day feels like a little bit faster. But anywho, U.S. life expectancy around 79 or so, but certainly you'll have patients well in excess of that. And so it's important to remember that you just don't want to start a lot of medications on these patients, because similar to how pediatric patients, they change pretty rapidly on the early stages of life. These older patients are changing as well, right? So what are some of the changes you would expect to see with these older patients in regards to medications? Decrease clearance. All right, so like decreased clearance is going to be an issue, right? So again, not only from a renal perspective, we'll see from a hepatic perspective, right? It can be one big thing. What else? How does that change usually? More fat, less muscle, right? So that's going to be changing primarily what for in relation to drugs? Volume distribution is going to be massively affected, right? So again, lipophilic drugs should have an increased or decreased volume distribution. Should be increased, right? Because there's more fat tissue to distribute into. We'll see that muscle mass is going to be important for certain tests we're going to be doing, especially when it comes to excretion. So I'll talk about more in detail later. So anyway, yeah, so think about the kinetics of it. We'll talk a little bit about the pharmacodynamics of things as well. But again, when we're talking about these medication lists for these patients, what else is going on with their medication lists? Polypharmacy is going to be huge, right? So you're going to find patients who are, and again, if you ever get an opportunity to do like a brown bag sort of event, I remember when I did this in probably first or second year of pharmacy school. We just went to a nursing home and they said, all right, everyone bring out your meds. And so you'd have people would just come out with these like baggies that are just like full of these bottles, and like, this one's from 1972. Like, why do you still have this? Meds that haven't been on in years, meds that expired years ago, things that two different prescribers prescribing the same med in some cases. It's kind of a crapshoot in a lot of cases. So again, polypharmacy is super, super important. We're going to look at some ways we can try to mitigate that if we can. But anyway, so let's talk about kind of the specifics here. The assessment of the geriatric patient is very important here, and so we can see that not only from a functional standpoint of them being able to take their medications, but also looking at their kind of the cognitive ability as well, right? Because that typically only gets worse as you get older, so that can be a big issue. So, what other things might you think? What other changes might impede the ability for an elderly patient to take their medications? Mentation, obviously, right? So again, do they even remember to take their medication, or do they remember that they had taken it already, right? So we'll talk about some ways that they can kind of help themselves with that. We get numerous phone calls to the poison center where they say, oh my gosh, I took my medication already and then I forgot and I took another dose, right? We get those calls all the time, very, very frequent that it occurs. What else? Yeah, so okay, we'll get to vision, but what about arthritis? About how that can affect? Can they even open the containers, right? So oftentimes, a lot of pill bottles usually come with what sort of packaging? Not child-proof. There is no child-proof products out there. I can guarantee you there's child-resistant. Question of how resistant it is up for debate. However, oftentimes I find that those packaging, those methods of packaging tend to keep more elderly patients out of them than they actually do children in a lot of cases. But yeah, so arthritis can actually get the pill bottles open, right? That's why when you go like the Walgreens or something, they'll have like a little cap that is actually reversible. One's just kind of a screw on, the other one actually has like the actual child-resistant sort of locking mechanism to it. What other type of dosage forms might it be difficult for a patient with arthritis or say rheumatoid arthritis to use? Injectable products, right? Absolutely, injectable products. If they cannot actually have the dexterity to administer it to themselves, that can be important. What other sort of medications? So oral medications. Yeah, so they have dysphagia, right? That can be one thing. But going back to the arthritis specifically, what other medication do we remember? Talked about like in the first semester that required a lot of dexterity to administer effectively. Inhalers, yeah, inhalers are super, super important, right? So we see a lot of inhalers are very difficult. If I have a hard time being able to coordinate pressing down that multi-dose inhaler and being able to inhale it appropriately, that can lead to drug ineffective or less efficacy because they're not actually able to absorb as much as the drug as they should, right? Right. So, and what about vision? Yeah, they can actually identify what medications they're actually taking. I don't know if I mentioned this story before, and I was on rotations, and I was in like a little family practice kind of pharmacy. I had this one lady who came in. She was probably on 12 or 15 different medications, but she had this system where she was able to put different markings on top, like she's Sharpies, and she would put them on top of the pill bottles, and she would know instinctively which medications they were. And actually, I quizzed her on it. I was like, this one has a red triangle on it, and she was like, oh, it's my metoprolol. I was like, all right, this one has a blue circle, and she's like, oh, that's my sertraline. You know, like she just knew it, and I was like, wow, that's great. Is every patient going to be like that? Unfortunately, no. It's probably the definitely the exception and not the rule. So vision can be a problem with those patients. Anything else you can think of? Those are the big ones. We'll talk about more as we go through it here. But again, remember, it's really important when you're doing these assessments to look from a kind of an interdisciplinary sort of standpoint. So again, make sure you're getting not only like your pharmacy friends involved, make sure you're getting your PT/OT friends involved, make sure you're getting your nutrition friends involved, because you need to kind of look at it from all aspects to make sure that patient's going to be kind of, you've kind of considered all facets of things. Okay, so again, looking at their activities of daily living, just determining, what are their abilities? What can they do for themselves? What they cannot do for themselves? And of course, along with that, as they kind of lose more functionality, who is performing those duties for them? Are they in an assisted living facility? Do they have kind of a live-in caregiver? Do they have a home nurse that can help with these things? These are things to consider because, going to a nursing home, is it typically like, one-to-one care, 24/7? No, you got patients that may not get seen that often for days, a week sometimes. So it's very easy for them to kind of miss things versus if you have someone who's a caregiver who's there 24/7 that can kind of help them out, right? So other things to consider there. Looking at their nutrition intake. So again, we mentioned their body composition changing. So certainly more fat, less muscle mass, but also looking like, are they getting appropriate nutrition? Some people have issues even getting food in the first place. You see this kind of really poor dentition here. Are they actually able to consume and get enough nutrients as they should? That can be affecting their certainly different disease states, can worsen them in a lot of cases. Certainly can affect how drugs are going to be processed as well. That's certainly things like chronic constipation, CHF, cancer, dementia. All of these things can be big players here. So just other things to consider, other questions to ask about the patient to kind of determine kind of what's going on with them. Other things, what do we often tell, like especially older women, to make sure they consume a lot of in their diet? A lot of calcium. And where do you find a lot of calcium? In a drinkable form. Dairy, right? So kind of trying to do leading questions here, but all right, a lot of dairy, right? So a lot of milk. And again, we already mentioned that milk is huge for what with medications? Binds a lot of types of medications, right? So imagine you have a patient who's on a fluoroquinolone for a UTI, which you probably shouldn't use too often, but let's say, for instance, you did. They have hypothyroidism, and they're taking all their medications with milk. A lot of those get bound up by calcium, right? So these are things to consider. Also think about iron binding up a lot of medications. So again, these are things you have to ask, see when they're taking them, how are they taking their medications, because that can influence how well the drugs are going to work in the first place. Have them, do things like recall, the food, the drinks, the vitamins, things like that they've consumed in the past 24 hours to get a sense for kind of what their average is. One of the big things I had to do very frequently when I was working with patients on warfarin, it was a Coumadin clinic, and we were testing INR. One of the big things, what do you think I had to ask for from a nutrition standpoint? Leafy greens. Leafy greens, right? And again, this was in Putnam County. I was doing this in Palaca, Florida, right? People there love their greens, right? So they love collard greens, they love spinach, they love kale. Usually they're growing it in their backyard. And so I had to ask them, like, okay, well, how much are you eating this stuff in a week? What do you think is your average? And I can ask them, how much vitamin K do you intake? They're not going to know that sort of thing, right? But I ask them, like, well, how much spinach do you eat? How much kale do you eat? Like, these are things you can ask to get an idea of kind of what their average intake is. And the important thing with warfarin is what? Tell them what? You tell them, like, they can't have any green leafy vegetables? Need to be consistent, right? Because again, if they have a lot of green leafy vegetables one week, what do you think that would do to their INR? You have a lot of vitamin K intake, and what do you think that would do to their INR? Decreases it, right? It would get it back close down to what's the normal? Well, what's normal for me and you? Say someone who's not on warfarin, 1, right? So a normal person would be 1. As they get more vitamin K intake, that's going to drive that down closer to 1, right? versus if you were to have someone who had, say, they were eating spinach pretty regularly and they stopped eating it altogether, what do you think INR would do? It would increase, right? So that's why we had to tell them, hey, be really consistent with this stuff, because you go from week to week and you find the INRs are kind of going all around the place. That's when we're like, what are you eating like? What's your diet like? What are you doing consistently or not consistently? So those are questions to ask. So other things as well is like, what's their water intake? What do you think dehydration could do to some of these patients? So it can increase, basically the blood volume starts to concentrate, so that can increase blood levels of certain drugs, so that can be affecting certain things. What do you think it does to renal function? Well, I'm going to hurt it, if anything, right? So again, this is where we oftentimes would run into issues where patients would be in the nursing home, they would get sick and no one really kind of see them for a few days, and so they get very dehydrated, they weren't taking enough water, and then their blood levels of certain medications would go through the roof, and then they come in and see us. So I've seen several theophylline overdoses that were not technically overdoses, it was more of a chronic sort of issue to where, they were dehydrated, the renal function took a hit, all of a sudden theophylline levels through the roof, right? So again, these are things to ask, how much water are you actually intaking, make sure they're getting a good, consistent amount. So again, I also ask about alcohol. So again, alcohol could be causing what sort of effects? Yep, so it could be hurting liver function, right? So if you have a lot of drugs that are hepatically metabolized, that could be affected by that. What else? Anemia. Yeah, so potentially anemia could be a causative effect, could be due to alcohol intake. What do you think alcohol does to your mentation? Yeah, usually decreases. I don't see, everyone might say, oh, I drive better when I'm drunk. How many people are actually correct when they say that? 0, right? So typically, that increases your risk for falls and increases your risk for injury, things like that. So again, other things to consider. And then, again, looking at not only the prescription drugs they're taking, but also what are they taking over the counter, right? What can they get without a prescription they may be self-medicating with? Maybe their friend told them, hey, this stuff's really great, you should try taking this. In addition to over-the-counter and prescription meds, what else might they be taking? What else can you get, like from the GNC? Supplement, right? Herbal supplements, right? So again, not all supplements are created equal, and not all of them are going to be completely innocuous when you start to combine them with prescription medications, right? So again, some of them can cause very significant bleeding risk, right? What's an herbal supplement you can use for depression? St. John's wort, right? You already know that has huge ramifications for CYP3A4 because it's a big CYP3A4 inducer, right? Remember, it's an inducer of CYP3A4, but then also what else could it incite in someone who's maybe taking something for depression? Serotonin syndrome, absolutely, right? So again, these are all things you need to be asking questions about, because they may not really think of their herbal supplements as drugs, but again, you need to treat them as such. You need to be able to kind of identify that. I've seen one orphan patient who came in, she was trying to take ginkgo for, what do you think they took ginkgo for? For their mind, for their memory, right? So she was taking it for memory, didn't realize it had an inherent bleeding risk associated with it. That combined with a warfarin, guess what? Huge hemorrhagic stroke, died, right? So these are things you need to make sure you're kind of screening for. And again, I'm not going to teach you every single herbal supplement, but look it up, right? That's the main goal here, is when you guys get out there and practice, like look stuff up to at least make sure you're making an educated decision before you decide to prescribe something or not prescribe something, as the case may be. Other things we're going to be looking at weight, make sure they're eating appropriately, but also what type of patients, could increasing weight be kind of a problem for? I guess more of like a fluid issue. Yeah, so like CHF patients, they should be weighing themselves daily to make sure they're not having a lot of fluid intake or fluid retention that's happening there, because that could cause an exacerbation of that, right? So again, all things we're monitoring for. So then when it comes to laboratory tests, again, these are things you would, kind of commonly try to either get a baseline or with follow-up. Certainly with CMPs, you're looking for, certainly kidney function, based on their BUN, creatinine. What else can you look for on a CMP? Liver function, good. What else? Electrolytes are really important. What electrolyte might you look for in a patient who, say, has poor renal function? Potassium. Potassium is huge, right? So again, high potassium can lead to cardiac arrhythmias, and that's something you have to watch out for with what other heart medication? And Professor Lack might have mentioned it. Yeah, digoxin, that can actually cause hyperkalemia in and of itself, right? So that can be, kind of synergistic there. But you mentioned diuretics. What do diuretics typically do? But yeah, hypokalemia, right? Because it causes you to urinate out the potassium there. So again, these are all things you can monitor for. Make sure you're not going to see big electrolyte changes. Sodium is really important, especially for neurologic issues. If you get really hyponatremic, that can lead to seizures in a lot of cases, and altered mental status. These things you have to be monitoring for. Obviously, glucose is monitored on there. Let's see what else. Certainly cholesterol you can be looking for, especially if they have hyperlipidemia or high-risk cardiac history. A1C is obviously for the betas, right? So you're monitoring for their kind of average blood sugar over the past 3 months or so. CBC, UA. These are all the things you'd be kind of routinely monitoring for. Now, when it comes to certain assessments of at least we'll talk about kind of organ function just a little bit here. But again, the big problem with these patients, or one of the big problems, is polypharmacy is huge, right? So again, 5 or more medications you start to consider to be polypharmacy at that point. And it's easy to imagine how someone can be on that many drugs, right? So imagine you have someone who has, say, had a previous MI, now they have CHF. So what medication should they be on? Probably on an ACE inhibitor, a beta blocker, aspirin. The CHF, they may also be on what? Diuretic. What else? Other drugs might be on amiodarone potentially, right? So what about from the cholesterol standpoint? Yeah, they might also need to be on a statin as well. So again, we're already up to 6 medications, right? Again, imagine if they're had diabetes, right? So now they're on metformin, maybe on their glipizide. So you can see how the medication list can really kind of blow up at a pretty easy rate there. But anyway, some of the reasons why we're seeing more of this is, one, we're seeing longer life expectancy. So the longer you're living, the more diseases you're going to kind of accumulate over time, the more drugs you're going to have to be on, more chronic illnesses we're seeing there. And then looking at the actual practice guidelines, typically you're starting to see, very rarely you see a guideline come out and say like, oh, actually you can stop giving as many of these drugs. It's usually, if anything, you're trying to add on more drugs as time goes on, it seems like. So again, more of the, from a medical legal standpoint, you want to be practicing the guidelines. You want to make sure you're practicing evidence-based medicine. So you may have to, prescribe a lot of these medications, depending on your patient there. So, again, looking at, age, the patient comorbidity, typically you're going to be seeing, patient, imagine had osteoporosis, osteoarthritis, diabetes, hypertension, COPD. They could be on 12 different medications at 5 times throughout the day. And again, how likely is it they're going to be 100% accurate with taking all of that or complying with that? Highly unlikely, right? It'd be, even for the best of us, it would be very difficult for us to keep up with that kind of regimen, right? And again, usually when you get hospitalized for one of these, say they have COPD exacerbation, do you typically go out of the hospital on fewer medications than you started with? Not routinely, right? You typically are going to have something added on. Maybe you're coming out on a steroid, or maybe they're adding on something else you may not have been on previously. So typically that is another big source for new medications. Now, are all these drugs coming from the same provider? Not always, right? So again, you have to worry about which providers are writing for this. They may be seeing their endocrinologist, maybe seeing their rheumatologist, maybe seeing their primary care provider, maybe seeing all these different people. And again, they don't all communicate with one another. So it's one of the big ways that you can kind of catch that sort of thing. Maybe you can catch it at the pharmacy. Like maybe you might have like a call, say you write for new medication for a patient, and get a call from the pharmacy and be like, hey, they're actually on these antagonistic medications from this other provider, and you'd be like, well, shoot, I had no idea, right? So again, that's why doing a thorough medication history is so important. Make sure you're asking all these questions. What other providers are you seeing? Are they prescribing any medications? That's an important thing there. But again, can you always catch it at the pharmacy level? Why not? Different pharmacies, right? So again, if I get a really good deal on my, metformin at CVS, but then I can go to Walmart and get a good deal on this drug, because again, typically older patients need to be a little bit more thrifty, usually on a fixed income, if any income, and so they need to be cognizant of things like that. So again, they may not all be getting everything from the same pharmacy. It'd be nice if we had kind of one centralized database, kind of like that eForce for narcotics, if we could do it for all medications. However, we don't have that available to us. We have to kind of do our due diligence, do the best we can. And again, just by asking the patient and trying to get a good history from them, or their caregivers if they don't really have the mentation to remember everything. So again, obviously the consequences of this, not only did it have, oh yes ma'am.
So you said that software that you have that can track a patient's medications through
only narcotics.
Oh, just narcotics.
Just controlled substances, okay. Right? So I can look to see where they filled oxycodone. However, I can't look to see where they filled every other medication, right? Why do you think we don't have that?
Why don't we have that?
So why not? What do you think?
That's a good idea.
It could be an expense issue, right? What else? It's a lot of data. That could be a concern. Some people feel it's an invasion of privacy. Like, why do you need to know? Why do you need to have access to be able to see every medication I'm taking, right? So there's usually a lot of the detractors will say from a kind of a privacy standpoint, they feel like Big Brother pharmas may be watching you. Who has access to that data? Things like that. So again, there's a multitude of reasons that I feel like it'd be great if there was one. It's really nice when you have like big systems where patients only come to you. So like instance, the VA, like everyone, if you're a vet, like you just go to the VA and you only go to VA facilities, you have all that information available to you, and it's a little bit easier, right? But if you don't have something like that, then you're kind of out of luck. It's really nice for us at Nemours because we have so many different subspecialists. Like, if they're coming into the ER, but they're our neurology patient, we have a lot of information that we look at all those notes. We can look to see what medication they've been prescribed. Makes it very easy, but unfortunately, don't always have access to that sort of information. Yep. So again, other reasons this could be bad. So again, imagine more drugs, more likely to see drug-drug interactions, more likely to see side effects associated with that. And again, compliance is going to be the other big thing. So again, are their disease states getting worse, or are they just not really being compliant to the medications that you prescribe to them? So, medication failure is something you have to kind of investigate from that standpoint as well. And again, falls are huge because again, so many of the medications we're going to be prescribing, antihypertensive, CNS active medications, can increase your risk for falls. When you fall, what do you have a risk for? Fractures, or say they're on an anticoagulant, they can develop bleeds, right? So these are all things that can come as a result of that, and it could be due to the medications you're prescribing them as a direct kind of cost for that. So, all right, any questions from the first section here? Would you like a joke to stimulate your wakefulness a little bit? Okay. What's the difference between an alligator and a crocodile? How can you tell the difference? One you'll see in a while, one you'll see later. I never claimed it was a good joke. It said it would be a joke. Anywho, all right. So looking at the compliance issues with these elderly patients, so certainly complex dosing schedules can be important here. So, if they're having to take one thing 3 times a day, one drug twice a day, one drug with meals and at nighttime, it gets very, very complex in a lot of cases, especially with multiple meds. And so you imagine the economics of it. So again, if the patient, you think an elderly, thrifty kind of patient, they're like, well, it said to take it 3 times a day. Maybe I'll just try to get it twice a day, and then it'll last me that much longer. I won't have to go to the pharmacy as often, right? So these are little things we'll kind of think of to try to kind of skirt around having to, pay for kind of the full amount that they actually need. And so again, when they come back into you and you're like, okay, are you taking your medications like I told you? What do they say? Of course, yeah, of course I am, right? Well, your blood pressure is still not under control. Your lipids are still out of whack. These are things that you have to think about. This kind of intelligent non-compliance where they're being kind of deceitful, right? And again, it's not out of any kind of malice or anything. It could be related back to the economic issues or other kind of factors. Certainly lack of support can be a problem here. Mental decline, if they can't remember which drug to take and when to take it. Have they already taken it today? Who's to say? So that can be a problem here. I mentioned visual impairment being a problem. Certainly if they have dysphagia, so imagine later stage, Parkinson's patients, or if they have had a stroke previously, things like that can make it very difficult. How could you get around that? Possibly liquid medications, and maybe switching, just like you do for little kids, switch back over to, because when you think about it, what's the difference between a really old person and a very young person, right? They both are incontinent, they both can't really remember what's going on, they have a hard time swallowing pills. So again, there are some similarities there. So anyway, not to disparage the elderly, I'm just kidding. Anyway, I hope to become one someday, right? May not happen, but anywho. So again, think back, to they cannot swallow. Maybe we can give them an oral liquid, right? Or what other ways could you get around their ability to swallow? A disintegrating tablet, yeah. So if an oral disintegrating tablet's a good one, yeah. I didn't think of that. Patches, the transdermal drug administration is a good one, or injectables, if that's appropriate. Think about that. Why do you think they would have decreased venous access? They're frequent flyers. They're coming to the hospital all the time. They're getting stuck all the time. They can be very, very difficult sticks, right? Because again, that tissue will start to fibrose, and it'll be very difficult for them to actually have good IV access. So finding a good vein on some of those elderly patients can be pretty tough sometimes, right? Especially if they come in there dehydrated, that could be another reason why they're very difficult to get a good stick. And then patient willingness to adhere to treatment. You may find some older patients are just like, yeah, this may add an extra couple months to my life, but I'm kind of miserable anyway. I'm kind of done with life, right? You may get to that point where they just don't really want to be adherent to treatment just because they're like, what's the kind of benefit at this point? They may be only experiencing side effects and not necessarily a whole lot of that extra benefit there. So, and again, when you get to that kind of end of life, we're starting to get to a point where it's around maybe 6 months to live or so, kind of on an estimate there. And you got to really kind of prioritize what's important for them. So, for instance, if they are having, having cancer, and say they're having a remission or having a relapse of cancer, and they're really at a point where you're really not going to expect to extend life very much longer, you need to start to look at not necessarily the quantity of life but the quality of life, right? And what do you call that when you're kind of treating those patients really end of life, trying just to make them as comfortable as possible? Yeah, palliative care, right? So again, it's palliative care. That's really, really important for this kind of end-of-life patients. You do want to make them as comfortable as you can. One of the things that's kind of interesting is that if you remember back to our opioids, what was one of the big kind of dangerous side effects you would see with that? Respiratory depression, right? And we mentioned what is it doing? Why does it cause respiratory depression? What does it kind of blunt the brain's response to? Carbon dioxide, remember? So they have a decreased ability to kind of respond to that increased level of carbon dioxide. And so actually one of the interesting things that my wife taught me, her being, doing a lot of pain management stuff, she did a lot of palliative care service, especially at the VA when she was doing it during her residency. And one of the things I thought was interesting is these kind of end-stage COPD patients, right? So again, end-stage COPD, like they just have a really hard time just oxygenating themselves appropriately, and they get that air hunger, they get that CO2 buildup, and it's really just, very, very uncomfortable for them and a lot of pain. So what we'll do is we'll give them some mega doses of opioids, and they will actually blunt that respiratory drive on purpose. So again, yeah, they may not be oxygenating 100% like they should be, but they also don't have that same kind of air hunger that they were having because that CO2 drive is kind of blocked to some degree, and it makes them much more comfortable, right? So again, we're not extending their quantity of life, but their quality of life is now drastically improved, okay? So some of the things you may have to kind of reprioritize for them as they get a little bit older and closer to their end of life. All right. So again, earlier on, we're kind of doing more treatment of disease, more life extension, but at a point, this is going to become the bigger priorities is palliative care, and then of course, afterwards, focusing on the family, making sure they're well taken care of from a kind of a social, psychological sort of standpoint. What do you call it when a patient says, I do not want any kind of life-saving measures provided for me? A DNR stands for? Yeah, do not resuscitate. So again, that can be really important to make sure you're actually kind of looking specifically at what the DNR says, because again, in some cases you may find certain treatments the patient is okay receiving, and in some cases they may not want to receive anything, right? So for instance, they say, well, I want a DNR, I don't want any kind of heroic measures taken to bring me back to life. However, if there's an infection, can they get antibiotics, right? So again, yeah, maybe they want antibiotics, maybe they don't want anything at all, right? So you have to look at the specifics of the DNR to kind of figure out what's important or what the priorities are for that patient. I actually had, this is kind of a random tangent, but I remember Iris had asked about this a couple weeks ago. But if you have a patient with like an implantable defibrillator, how do you normally turn that off? Like, how can you tell when the patient's really dead? Because if their heart's not being on its own, that's normally the trigger to start that implantable defibrillator, right? Yeah, you have to put a magnet on it. So in order to turn it off, you have to put a magnet on it. And so we had this one case, this is a very, very odd kind of weird situation. I was on rotations. It was during like one of my years of fellowship, and I was on rotations in this medical ICU, and he had this elderly lady, and she was there's a question whether she's actually DNR or not. For whatever reason, it was kind of unclear to the docs, if she actually was. But she had an implantable pacemaker, and so it was one of those things where like, okay, we're gonna let her be a DNR. We're just gonna say, hey, we're not gonna do anything. And then later on, they're like, well, maybe we should. So anyway, the nurse basically came up and said, hey, the patient's coding. We need, do you want to do anything for her or not? And at this point, she already had that magnet placed on her, try to cut off that implantable defibrillator. So they said, well, she's coding right now. Let's go ahead and run this code. Okay, so we go back, and of course, one of the things you can do for a patient when they're coding? So you do epi, but not non-drug wise. You defibrillate, you shock them, right? So again, the question, okay, so this lady has a big magnet on her, and then they decided to shock her. Where do you think that electricity went to? Up to that big honking piece of metal on her chest, right? So when that conducted through, all of a sudden it's conducting electricity there, and there's starting to be this smell. And I was like, what the heck is that smell? It was burning flesh, because we were basically cooking the patient. Like it's a very bewildering situation to find yourself in. Of course, I was just in the corner with the epi, and I was like, I don't know what's going on here. But Eventually, just like, we're just going to call this and just call it a day. So, anywho, these are things you might encounter, especially with some of these palliative care patients. But anywho, I probably should just strike that out, so I know there's no legal recourse for that later on. Someone tries to come look at it. There's a video where you're saying that you cooked this patient. Anyway, so let's look at the physiologic changes occurring with these patients. So certainly with the cardiac side, certainly you can see things like increased blood pressure. You're going to be seeing impedance to that left ventricular ejection rate. That's where we see a lot of that genesis of CHF kind of come about from there. Reduced heart rate associated with that. The renal function is going to definitely be taking a hit. Certainly, how do we measure renal function? Their GFR, their creatinine clearance, we're going to be measuring that. We're going to be monitoring that. Typically, it's going to be taking a hit as they get older, right? So we're going to talk about some specifics of that in just a minute here. But they also have a decreased ability to maintain good acid-base balance. So they tend to when they get acidotic, they get really acidotic compared to the younger patient with a little bit more reserve there. So again, everything just kind of break down as they get older. And so you can see here, GFR is going to be taking a pretty, everything is going to take a gradual decline here. The respiratory function, pulmonary function, cardiac function, I should say, everything's going to be making a decline here. And that's important because it can be affecting how we process our medications, right? So for instance, if we're having decreased blood flow to certain organs, say for instance like the liver, what do you think it's going to do to drug metabolism? It's going to go down, right? So again, if you're not supplying as much blood carrying drug to the liver, if you slow down the supply, you're not going to be able to really kind of break down as much drug, right? So again, things like CHF can be an important disease state where you see kind of a lot of backflow in the venous side. You're going to see a lot of decreased metabolism of drug in those cases. So these are things to consider. From the GI standpoint, what kind of changes do you think you'll run into? Yeah, decreased absorption, and again, this is probably going to be one of the organ systems that takes the least amount of a hit, but is probably of more concern from usually like a drug-drug interaction standpoint, like a drug-food interaction sort of standpoint. But usually you're going to end up seeing decreased absorption, decreased motility. A lot of these patients have things like chronic GERD and things like that, so they'll be taking a lot of antacids, or they'll be taking a lot of PPIs, H2 blockers. That all can impair absorption of certain drugs. We mentioned calcium typically needs what type of medium to be absorbed in? More acidic, right? So again, if they're increasing the pH of the gastric contents, that's going to decrease absorption, worsen osteoporosis, etc. So you see a lot of this kind of make kind of a sick cycle where one thing kind of exacerbates another there. But looking at absorption, again, no major changes are occurring here. So typically you may slow down the rate of absorption, but in general, most things will still be absorbed as they should. But again, watch out for these dietary changes. Look for increased use of like OTC medications like laxatives or antacids. All of those can affect how well a drug can be absorbed potentially. Also look at things like impaired gastric emptying, like diabetes, if gastroparesis. That can also delay absorption of medications as well. Now, the big things to focus on from the drug standpoint are going to be kind of more the distribution and the metabolism and excretion of medication. So looking here at drug distribution, I've already mentioned this. Typically, they're going to have a reduced lean body mass, which means they're going to have less muscle, but they're going to be producing, have a higher adipose tissue content. So imagine looking at a young adult versus an older adult. You see here that percent body water tends to be diminished in older patients, and dehydration can be kind of a chronic issue for a lot of them. Lean body mass is going to go down. You're going to see body fat typically go up for these patients. And then looking at things like serum albumin, they can actually have a big effect on drug distribution. In which ways? What type of drugs do you think might be affected by that change in albumin? Yeah, highly protein-bound drugs, right? So again, if I have less albumin, less of that's available to bind drugs. I'm going to do what to the volume of distribution of those medications? It'll typically go up, right? Because again, you're going to have better tissue distribution because it's not being bound up by the drug right there in the bloodstream, right? So again, that can have an effect to increase the volume of distribution of some drugs. Kidney function is going to be going down, so kidney weight tends to go down. Hepatic blood flow can be pretty markedly decreased here, which can affect metabolism. So again, these are kind of just natural changes we're going to be expecting in these older patients. And so again, why we need to make sure we're looking at like as one person mentioned, like what happens if you have like a really kind of muscle laden adult, some like a ripped grandpa or something, you have to take that into account. Like you have to look at the patient. If it's a 90-year-old skeleton of a person, like they obviously have a lot less muscle mass. That will influence a lot of your kind of assessment of the patient versus someone who has a ton of muscle mass because they've been actively working out and consuming a high protein diet. So again, everyone's going to be a little bit different from that standpoint. So, as I mentioned, the protein binding, you're going to see decreased serum albumins, not only due to, most of those will be related back to nutritional status. As their protein intake goes down, they're not being well nourished, you're going to find that they'll be producing less proteins. And then actually, if you get into nutrition, you'll find that's actually one of the big things, one of the markers that we'll actually look at to determine the nutrition status of a patient. How much protein are they making in the serum? If they're not making very much, it means their body doesn't really have enough kind of building blocks to work with. They probably need more nutrition. So that's one thing you can see. You see some increases in other proteins though. So for instance, alpha-1 acylglycoprotein, this tends to be increased in elderly patients. Again, clinically not going to be as relevant as albumin, but one thing you may see. And again, it's just going to be affecting that free fraction of drug. Less protein means you're going to have a higher free fraction. It's going to mean you have more drug available to interact with the receptors, and you can see more effects there. Okay. So think back to that phenytoin example, or said phenytoin is normally 90% protein bound. If you have less albumin, that percentage is going to go up, and you can see more side effects from that. Right. All right, drug clearance is going to be really, really important. This is one of the biggest things you need to monitor for these elderly patients because, again, if this goes down and you're not monitoring for it and they're on the same level, same dose of drug, what are those levels going to do? It's going to go up, right? And you're going to see toxicity from that. So this is one of the biggest things I see with those nursing home patients who are coming in. They get sick, they get dehydrated, or just over time their renal function has been diminishing, and no one's addressed that with their drug dosing. This is when they end up in the hospital, right? So again, very frequent cause for that. And so you're going to see decreased function here. You also have to look at the fact that their serum creatinine is not going to be proportional to the decrease in their renal function. So what do I mean by that? So as they get older, muscle mass tends to decrease, right? And where does creatinine come from? From the muscle, from the breakdown of muscle tissue. So again, you're going to find with elderly patients, they cannot produce as much creatinine as a younger patient might. Okay, so when you're looking at, let's say, a 90-year-old patient who's coming in, and the creatinine, say, it's kind of like a normal creatinine, you think? Like 1, 1.2, something like that for like an adult patient. If it comes in, it's 0.8. What might you assume about that patient? So, wow, they got really good renal function. They're able to clear that creatinine no problem. Not really. They just don't have a ton of muscle mass to actually produce that much creatinine in the first place. So you can falsely overestimate what their actual renal function is, and that's why it's important we have to look at our calculations when we're kind of figuring that out. So I'll show you an example of that in a second. So that decreased muscle mass or decreased renal function, they're going to have an increased half-life of the drug, so it's going to stick around for longer. You're going to see a much higher risk for toxic concentrations. We need to adjust for that. And again, hydration status can affect that as well. Dehydration will do what to the renal function? I mentioned will decrease it, right? So less renal blood flow occurring because again, the body's trying to send blood flow to the head and the heart. Kidneys can take a backseat to that. And so again, you see that dehydration, that pre-renal kidney injury. Have you guys got your nephro yet? We'll talk about that a little bit later, but there's different types of kidney injury you can have, but there's pre-renal kidney injury, and that can be related back to blood volume being diminished. And so dehydration is a big cause for that. So again, you got to be careful with that. Make sure they're well hydrated. So normally we would use something like the Cockcroft galt, and this is good for most adult patients. And again, you need to know which equations are good for which patient groups, right? So the Cockcroft galt, notice what is taken into account here. You're taking the age of the patient, right? Hopefully we don't have any patients who are greater than 140. I can't think of any off the top of my head, but maybe if a Highlander or something was in your hospital and you need to monitor their renal function. And nobody? No Highlander fans? Well, I guess I'm the only one, right? Yeah, okay. Let's joke for 2 people. Anyway. Go watch Highlander, then come back, watch this video, and it'll make much more sense. All right, you're going to look at their weight in kilograms, right? And then you're also going to be using their creatinine. So again, if they have a higher serum creatinine, what do you think it does to the creatinine clearance? With it being in the denominator. It should decrease it, right? So higher serum creatinine means you're not clearing it as well. It means you have less renal function occurring there. So again, it's just a surrogate for using serum creatinine to get this creatinine clearance. Not the same as GFR, but it's a good estimation of GFR in most cases. And again, make sure you multiply by 0.85 for women. Why is that? Typically, females have less muscle mass in general than same weighted, same weight male patient in general. Again, you can find some people that are not following that rule, but in general, this is where you're going to be multiplying by. However, you may find that especially in extremes of age, or if you have patients who cannot produce a lot of creatinine because they have, say, decreased muscle mass, this is not going to be working so well. You might have some issues where you're kind of overestimating renal function. And in fact, what I will do in most cases, if I have an elderly patient who comes in, and, like say they're 80, 90 years old and their creatinine is less than 1, I'll just round up to 1. I'll just use that instead because, I would rather underestimate their renal function than overestimate it from a drug dosing standpoint, right? Because I'd rather have levels be a little too low than too high and cause toxicity. However, there's different calculations out there. Here's an example. Here's the MDRD equation. So again, these are done in studies. They're validated, and then they will publish these. So it's a modification of diet and renal disease. And so this is really good for elderly patients, right? And so in this case, you notice here they're taking into account the serum creatinine, looking at their age, and then they'll multiply by that cofactor there if they're a female patient. And you'll notice here they'll actually multiply it by the subject is black. They'll multiply by 1.212, right? So again, they did this, and again, based on their models, they determined this to be the most accurate way to modify or to monitor someone's GFR. Again, just be able to calculate this on the test. I'll give you some pretty easy ones you can do without. I'm just kidding, though. That'd be really mean. You can't do a negative 0.203 exponent in your head. Amateur. No, I'm just kidding. No, but just know kind of what are the factors that go into this. Know that there's different equations that are good for different types of patients. Notice here these are not going to be good for pediatric patients. We have a different one we call the Schwartz equation we use for peds patients. So again, wherever you're practicing, make sure you're using the appropriate calculation in order to make sure you can properly estimate the renal function. Because again, this is not one of those things where you want to get it wrong, overestimate the renal function, have their levels go sky high, and all of a sudden they're having toxicity from that, right? We'll talk all about that more so when we get to the renal section later on in the next part of the class. Now, what if you had a patient who had, say, an amputation, say you had a diabetic who had a below-the-knee amputation? What would that do to their muscle mass? We would obviously decrease it, so I would decrease what? Their serum creatinine, right? And so what do you think that would do to their, we're using the Cockcroft-Gault equation, what do you think that would do to the creatinine clearance? It would falsely increase it, right? So again, those are other things you have to consider. Like, does a patient have an amputation? Because that's going to falsely overestimate what their renal function is. That'd be another case where you'd want to probably be a little bit more cautious, a little bit more conservative with your calculations when doing that. So again, all things to consider. Okay, getting into drug clearance from the liver standpoint, again, you need to make sure you have good liver blood flow. Otherwise, if it's not flowing, you're not going to be able to have those enzymes interact with the drugs. And so it can be important, especially for CHF patients or patients with a lot of venous distension, kind of impaired venous flow. And you may find that first pass metabolism can be affected here. Again, typically you'll find a little bit of decreased function in phase 1 reactions, minimal changes in phase 2, but primarily going to find more interactions that are coming about from a drug standpoint. So again, look if they're on a CYP3A4 inhibitor or a 2D6 inhibitor, things like that when you're running your medication list to see what's going to be appropriate for those patients. Okay. From a pharmacodynamic standpoint, are geriatric patients more sensitive to these drugs? Maybe, maybe not. In some cases, you're going to find that it could be a factor more of their altered pharmacokinetics. Once you've taken that into account, they're going to find that typically they have kind of lessened homeostatic responses to this. So you see a lot more orthostatic hypotension. We see a lot more, kind of dizziness and CNS changes that can occur from a lot of these drugs. You have to be careful from that standpoint. So again, look at things like their cardiac output. If they have postural hypotension, they have impaired temperature regulation, fasting blood glucose typically is going to increase as they get older, as they get more insulin resistant. So again, take into account these kind of changes and when you're looking at the kind of the interactions that are going on with their medications. Okay, so let's look at some specific drug class examples. And again, I'm not going to go over every single one of these, but just some kind of common pitfalls, some common issues you can run into for some of these. These are probably going to be similar to some of the ones you covered with Professor Lack already. So if I say anything contradictory or if you have any questions or anything, just kind of stop me. We can go into more detail on it. So I'm going to say sedative hypnotic agents. So what am I kind of referring to, do you think? Benzos, right? So all of our benzodiazepines. Also includes all your Z drugs, like those Ambien and your, not Concerta being amphetamine, but what's the other one? I can't think of the other sleep drug. Anyway, think about Ambien, Lunesta, those other kind of like benzo-like kind of drugs that can affect, what else would fall into sedative hypnotics? Benadryl, yeah, so a lot of antihistamines, the first generation antihistamines, a lot of anticholinergic drugs can kind of have sedative hypnotic sort of effects here. Even opioids can have those kind of effects, right? So anything kind of depressing mental status function is going to be important to look at here, right? So again, a lot of half-lives of these drugs can be increased, right? So again, you can see 50 to 150% increase in half-lives of some of these drugs. And for instance, if you're looking at something like, say for instance, something that has an active metabolite, right? So again, the parent drug is active, but also has an active metabolite. Those also tend to accumulate in elderly patients as well, which is why, you remember we talked about benzos, which are the ones we like to use for elderly patients. Remember, LOT was the abbreviation, so it's standing for what? Lorazepam or Ativan. You have oxazepam. You have triazolam and temazepam. Those are the 4 ones, LOTT. And again, those are good because, one, they're water soluble, in which, what do we say about the adipose tissue for elderly patients? Increased, right? So again, these are going to have, they're not going to have their volume distribution affected quite as much as you would have for a more fat-soluble benzo like Valium or diazepam that has a much higher volume distribution compared to younger patients. That's one good thing. They also don't have active metabolites, which is good because, again, active metabolites tend to have the same effect as a parent, and also are going to stick around for longer. So again, these are all good reasons why we like to use only specific ones, and again, just avoid them if possible for whenever you can, because they can see increased risk for ataxia, falls, altered mental status. And again, you don't know, is grandpa just, kind of getting more demented? Is his Alzheimer's acting up? What is it? Or is it the medications being prescribed for him, right? Which antiemetic drugs do you think we might give to, say, an elderly patient having, nausea, vomiting, that could fall into this kind of sedative hypnotic category? Scopolamine, yeah, that could be one. That's going to be more for more like vertigo kind of issues, like seasickness and whatnot. That would certainly be one that could do that. What else? Phenobarbital probably wouldn't use for nausea, vomiting. Yeah, so like the first, yeah, so Phenergan is kind of what I was going for. So again, think about like the kind of that antipsychotic kind of category of drugs, like those kind of first generation antipsychotics like haloperidol, Phenergan, all those drugs tend to have a lot of anti-muscarinic effects, tend to be very sedating, and it kind of falls in the same set of hypnotic sort of category there. Analgesics, as mentioned, opioids, typically you're going to see more susceptibility to those respiratory depressive effects. And again, you can find elderly patients with chronic pain issues, they can be on like mega doses of opioids. They can be on doses that would, a single dose of what their normal is, could probably kill any one of us, right? And so they can be a very, very big dose. This is actually where we saw some problems from a tox standpoint. Have you guys ever heard of like these pill parties? Some kids would do. It was kind of a little bit more popular back in the day, but basically you kind of raid your grandma's medicine cabinet, you go to a party, everyone kind of throw their pills into one big thing, one big bowl, and you kind of take stuff out and just try it. Obviously this is a bad idea. But again, Tide Pod challenges are sort of a thing now, so I guess, teens typically have less sense and more time than people with a little bit more forethought. But anywho, they would do this, but yeah, grandma might be on, 100 milligrams of morphine a day, and then, little Johnny gets a hit of that, and then he's going to be down for the count, right? So these are very, very dangerous, but they have a lot of tolerance to these drugs. So, but you typically don't ever lose that respiratory depressive effect, so it's still going to be a risk for those patients as well. And again, accumulated active metabolites. We mentioned something like morphine has those active metabolites that can actually accumulate in patients with renal disease and typically have kind of additive effects to the actual parent morphine can be kind of an issue there. That's why something without active metabolites, something like a fentanyl, might be a better option for those patients. All right, antipsychotics we kind of already alluded to, but like things like lithium. What's the primary way lithium gets eliminated from the body? Renal, right? Because it looks like what? Looks like sodium, right? It looks like sodium to the kidneys, so it eliminates it purely through the kidneys there. And so we find if you have depressive renal function, guess what? You're going to accumulate lithium. If they're dehydrated, guess what? You're going to accumulate lithium. It's going to be a big reason for seeing seizures, new onset seizures in the elderly patients with bipolar disorder, right? You got to watch out for that. Also, if they have bipolar disorder being managed with lithium, and then you add on, say, a diuretic for their CHF, guess what? Lithium's going to put them in kind of a more salt-retentive state. They're going to be more holding on to lithium. Okay, so again, all these things to make sure you're looking for these interactions prior to prescribing. Looking at antidepressants, older agents tend to be more likely to cause altered mental status. So, which older antidepressants do you think could do that? And TCAs are going to be the big one that would do that. Very sedating the TCAs tend to be, and so that could be a big one there. However, the newer agents tend to be much, much safer in this patient population. So SSRIs tend to be pretty good for the most part. SNRIs could be potentially bad for what type of patient? They have hypertension. This is maybe not controlled too well. It could be one. Maybe they have a history of seizures. Maybe that could be something that could kind of reduce their seizure threshold a little bit there because of that norepinephrine sort of effect. But again, just kind of look at the comorbid conditions, see what might be appropriate for them. However, what other condition would SNRIs be good for in this patient population, this cohort? Certainly the depression, but what else? You wouldn't really get that kind of reliable of an effect. But think about neuropathic pain. Remember, we use SNRIs for a lot of neuropathic pain. Think about diabetic neuropathies that occur. If they have Guillain-Barré, if they have any kind of neuropathic pain, SNRIs could be good for that, right? So you can kind of sometimes pull double duty if you needed to by using certain drugs. So consider that. Cardiovascular agents, again, antihypertensives are pretty notorious for causing a more orthostatic hypotension. You tend to see this more with things like agents that are directly acting on the vessel, so like more like calcium channel blockers, especially the dihydropyridines. You think alpha blockers are really notorious for causing this. Which ones do you think might be a little bit safer from that standpoint, from an antihypertensive standpoint? Like ACE inhibitors tend to be a little bit better because, again, they're not going to be directly causing direct vasodilation of the vessels. They're going to be working a little bit more indirectly by inhibiting the ACE system. So one thing you could try for this patient might be a little bit safer. But again, what's the main goal when you're starting these patients on a new antihypertensive? What's kind of the dosing strategy? Start low and go slow, right? You can always add more. It's hard to take it back once they're having toxicity there. And again, electrolyte imbalances are huge with diuretics. So again, if they're on Lasix, if they're on thiazides, any kind of diuretics, you're going to be losing potassium. They're going to be losing salt, and so they can have some major issues, especially if they have like any kind of arrhythmias, anything like that can be affected by that. And then looking at antiarrhythmics, again, due to the high prevalence of electrolyte imbalances, this can just make yourself more likely to have an arrhythmia. So if you're already hyperkalemic due to having poor renal function, and then all of a sudden I'm adding digoxin on board, digoxin raises potassium as well, more likely to see arrhythmias, right? Other things have extended half-life, like lidocaine is another big one. They'll have extended half-life due to poor hepatic blood flow. So again, just make sure you're looking at their hepatic function, look at their renal function to see if you need to adjust the dose. And again, it could be you have to adjust the dose down, or you adjust how frequently you give the drug to make sure you're dosing appropriately. And if you go to LexiComp and you're looking that up, they'll give you sections where it'll say, okay, here's the normal dosing. Here's what you do in hepatic dysfunction. Here's what you do in renal dysfunction. Make sure you look at those to make sure you're dosing based on what's good for your patient. All right. So with adverse drug reactions, as the number of drugs go up, you're more likely to see ADRs, right? You're more likely to see some kind of reaction pop up here. You know, the single medication, maybe say you have like 10%. By the time we're up to 10 medications, you're probably going to be nearly up to 100% likely to see some sort of drug interaction, okay? Not to take into account the OTCs they may be exposing themselves to, and also herbal supplements. We've kind of talked about already. So looking at some of the issues that can be coming about from the prescriber error. So again, not taking age-related changes into account. So for instance, if you're, say, you know, they're having a lot of anxiety or they're having trouble sleeping and you prescribe them, say, diazepam, right? That could be a prescriber issue, not taking into account their impaired, you know, their alterations in kinetics there and not using something like lorazepam instead. Look at things like, you know, patient compliance errors. We mentioned, you know, as compliance or as complexity of the regimens gets bigger or gets more complex, you're going to see less likely for compliance to be appropriate. And then also seeing multiple providers we've already kind of alluded to. So they see you for endocrinology and see you for rheumatology, and no one communicates together. This is where you see a lot of overlapping issues here. All right, and then you know, patients, as I mentioned, may not recognize certain products as medicine. So I mentioned BC powders and goodies. Older patients will just think, hey, this is just the headache stuff I take. You know, or something I take with the aches and pains. They don't think about it as being. Anyone know what BC powders or goodies actually is? Powdered aspirin, right? They may not make that association in their mind that, hey, this is aspirin. You know, this is the same thing I take for my heart every single day, right? So anyway, some of the things you should consider asking when you're kind of doing this kind of structured medication history. And again, this is when you come into the hospital, like come to the ER, who do you think normally does the medication reconciliation? Usually the nurse. Usually the nurse is going to be the first point of contact where they're actually going to do the medication list. And again, one of the things I run into, and again, it's no fault of the nurses, because guess what? She's super busy. She's got a lot of stuff to do, right? But what you'll find is they just want to get a quick list, and they want to get just the drugs, at least at the bare minimum, get the drugs that the patient's taking on there. But they may gloss over some of the more pertinent details, like how often are they taking it? What dosage are they actually taking? Again, from a pharmacist standpoint, I can spend 10 minutes asking every single question to get the full details, but the nurse is going to be the one who's going to have to, you know, take their vitals and get any kind of medication started, start an IV, all these other things. They have a lot of competing kind of interests, so they may not get the best medication history out of the patient, but usually you're going to be the first person to do that. However, this is when you can have errors where, say that you decide to admit the patient, and then the admitting provider has to go through that medication list and say, what do I want to keep, what do I want to discontinue? And we see a lot of errors that happen there, right? So we see a lot of things where the patient didn't have the right dose prescribed, or they're dosing things at the wrong time, you know, different things like that. So it's really, really important to get a good history. Make sure you keep this up to date as best you can. So some things you're asking, you know, are you using the drugs prescribed? Make sure you're taking the right dose, the right frequency, etc. Are you experiencing any side effects? What's the kind of the important thing to when you're asking this? I guess it's hard to ask that question, but make sure they know what are side effects, right? So it could just be thinking, hey, I'm just getting older. This is just what's going to happen, right? I just have diarrhea, right? Or I'm just constipated. I'm older. This is what happens. May not realize, hey, that could be related back to the drug they're taking. So kind of ask, hey, specifically, are you having constipation with this calcium channel blocker you're taking? Or are you noticing you're getting more hypoglycemic and you're on glipizide? You know, these are things you want to try to kind of lead the patient into trying to give you the right information. You know, if they are deviating from their prescribed regimen, why are they doing that? Is it because of side effects? Is it because of costs? Is it because of, you know, these are things you can kind of uncover problems early on to try to fix those. And, you know, obviously, are there any other medications that are not on the list? Are there any non-prescription drugs you're taking? You know, so you can say over the counter, but you know, they actually know what over the counter means. You know, I oftentimes ask, you know, anything you can get without a prescription. They usually kind of jogs their memory a little bit better for some of that stuff. Because most commonly, what do most people take over the counter? Tylenol, Tums, so acetaminophen, Tylenol, aspirin, ibuprofen, naproxen, right? And these can have some big interactions with a lot of disease states, a lot of other medications. So again, these over-the-counter drugs does not mean they're innocuous. It just means that they're just more available for patients. So again, make sure you get a good history of that. You know, asking about things like homeopathic drugs. We haven't really talked too much about homeopathic drugs, but what makes something homeopathic? Being non-judgmental, right? very, very dilute solutions, right? So again, I'm not going to get into the details on that, but they're very, very dilute substances. However, some of them come in sugar-based products, sugar-based vehicles, which may be interacting with their diabetes. So little things like that. So think about things like homeopathic drug, herbal medications, which again, these are not innocuous. Vitamins that could be interacting. Obviously, if they're taking a multivitamin that contains vitamin K and they're on warfarin, that could be something you need to know about. This is popular amongst, especially depending on certain elderly patients, but they might want to share drugs amongst one another, right? So, for instance, anytime you get a cold or something, you have someone's like, "Hey, I got some Levaquin. I can hook you up with that," right? Obviously, not super appropriate from our standpoint, but unless you ask the question, you may never actually find out they're actually doing that, right? Because again, the Levaquin, meaning fluoroquinolone, what are some side effects you can see with that? Tendon rupture, right? So they come and complain of tendonitis, right? Maybe that could be something that's not on their medication list. You'd have to ask them about. What else? Yeah, so that's going to be more like if you're prescribing it therapeutically and it's binding up with calcium. But think about QTC prolongation, right? You can see that. So if they had a cardiac dysrhythmia history, that could be important. Seizures can happen, especially if they're not clearing the drug very well, if they have poor kidney function. So again, I guarantee you their friend or the family member is not saying, well, what's your creatinine clearance last time you were here before I give you this Levaquin that I've had sitting around for 3 years? But they're not asking those kind of questions, so you have to be the one to try to figure that out. How about drugs from outside of the U.S.? The illegal substances or illegal drugs that are gotten from outside, because again, it's a felony to traffic drugs across state lines, that are not approved. Like there's laws situated around that with the FDA. However, you can order just about anything online, right? Especially drugs from Canada. People do this because why would they order drugs from Canada? Cheaper, right? So again, it could be a definite cost thing, right? And it's nothing to say that Canadian drugs are any worse. In fact, if you can get them cheaper, I say go for it, right? But you have to make sure you're asking the right questions, right? Make sure they're getting a good supply, not getting it from some shady, not going to like drugs with a z.ru to order their stuff. Like probably not super reputable versus some other sources, right? So anywho, any drugs that are no longer being prescribed, a lot of times you may think, okay, I'm going to discontinue this medication, but that message never makes it to the patient. They may not actually know to do that, and they could be taking something much longer than what they should be. And then when's the last time I checked expiration dates? Now, in general, I will tell you expiration dates are mostly bogus. When you get a prescription bottle from the pharmacy, anyone know how long that expiration date is typically for?
1 year.
1 year, right? Is the drug bad after 1 year? No, typically not, right? So again, most of the time these drugs will have extended stability much longer than that, even what's on the actual parent bottle. However, certain things do expire. So for instance, you think of anything that expires pretty quick? Yeah, nitroglycerin is a good one. That's a very good one. That one you want to replace after 6 months of it being opened. What else? Yeah, so especially because anything kind of an aqueous vehicle tends to be more likely to grow bacteria, right? So it can be more of a sterility standpoint. But a lot of antibiotics, especially like amoxicillin, oral suspension, things like that, those tend to break down pretty quickly. So antibiotics, liquid ones, they tend to not be very good after their expiration date. Right? Usually you get like 14 days or 7 days out of most of those. Anywho, so those are questions to ask. And again, I would have people bring out drugs that they've been taking since like the mid 90s, and it's just like, why do you still have this? But they have that kind of hoarding mentality. They don't want to get rid of anything. It could be potentially useful down the road. So, question, who's helping them take their medications so they can't do it themselves? Do they have any kind of dosage systems? So what are some systems that can kind of help them take their medications? Yeah, you have like a little simple pill box that will divide things up based on the day of the week or the time of day. It can be very useful. What else? Yeah, they can absolutely use technology to help them out with this. Sometimes they'll have alarms that are set up. There's services that will actually call you and say, hey, it's time to take your metoprolol. So different things like that. Try to figure out, what are they doing to best help them remember to take their medications. Do you have any problems taking medications? If you're taking an injectable product, is your arthritis preventing you from using it appropriately? If you're using inhalational drugs, is there what's your technique? Can you demonstrate it for me so I can see how you're doing it? Because, maybe their asthma is actually getting worse, COPD is getting worse, or maybe they're just not using their inhalers right? Eye drops, that can be really important, if they're actually getting the eye drops actually in their eyes, or if they're just, kind of ending up somewhere else on their face, or what's the other issue with eye drops you went into? It's hard to ask that. So yeah, is it dirty, right? So again, sterility can be a big problem with eye products because again, you want to be able to keep that product clean, make sure it doesn't go grody because then they can cause an eye infection. That's what do they do if they forget to take their medication, right? So you can educate them appropriately, like, hey, do they take it as soon as they remember? Do they try to double up on the next day? Maybe that's leading to toxicity. Maybe that's a problem. And then just any other kind of general comments, questions, right? So this is kind of the general flow of things. You'll get a good idea yourself once you start to interview patients, kind of what's the most pertinent, important questions to ask them whenever you're trying to get a good medication history. But someone's got to do it. It's important someone do it thoroughly to make sure that everyone has the correct information. Otherwise, you can really screw things up. One of the problems I run into with pediatric patients is that we mentioned that what's a more common dosage form that they take? Usually liquids, right? Liquid suspensions, solutions, anything like that. And again, what's a very important aspect of when you're writing a prescription for a suspension? The concentration, right? If you get the wrong concentration, you can really screw something up. And so I remember we had a patient who was on a clonidine suspension. The nurse, when she was typing in, she typed clonidine. She had a bunch of different options. She picked the first one she saw, and it being the wrong concentration. So when the doc wrote for the or reordered the wrong concentration, he did it for the same dose or the patient normally took. So it was like 3 mL or something, but it was like a tenfold overdose based on what we were going to be accidentally giving the patient. And so we have to make sure we're keeping those things straight so we can make sure we're doing the right calculations and not actually give too much or too little. So that's a pediatric kind of specific kind of issue we run into. So anyway, so again, just some examples of pill minders and things like that. They can kind of help them out. What do you think is a problem if you had, like, say, grandkids running around the house? They like to open them up and play with them. And, oh, look, there's candy in there, and I can take this candy and munch on it. Oh boy, now I've got a whole bunch of digoxin in my system. That's fun. Yeah, so we get a lot of pill calls, or calls to the poison center where they say, hey, grandma's calling up and say, little Johnny was running around, opened up, and I have no idea what he actually got into. There's just a bunch of them. Someone's on the floor, someone's, who knows what happened. So that can be a potential problem you run into. Really easy access for kids. Okay, so again, making sure some kind of practical points, make sure you're looking at the cost of all the medications, what kind of coverage does your patient have? Are they on just kind of basic Medicare? Or are they on, any kind of other supplemental kind of income, things like that? You want to typically prescribe cheaper things if you can. Sure, that brand new NSAID is, super effective and really good at what it does, but if, standard ibuprofen works just as well, just do that. You can get it for pennies based on what some of these kind of brand name only drugs sell for, yeah, they might have given you a great steak dinner, but, ibuprofen works just as great. Right. Anyway, I'm not cynical at all. Actually, in the pharmacy world, they really hunker down on not doing a lot of like drugs and company sponsored dinners. So I remember when I was a student, we used to be able to go out to like events all the time. I remember I got to go to like Ruth Chris, and I was like, this is great. I love being a pharmacist. And then the board of pharmacy came down. They're like, no, we're not going to do that anymore because this provides kind of bias in drug recommendations. And so that was very unfortunate. I almost thought about switching careers, but I was already way too far in at that point. So I said, nope. Free steak is not a good reason to make career decisions. Is basically what I'm trying to get at. Anywho, try to use medications. Try to use combination drugs if you can, right? So again, instead of using metformin by itself and glipizide by itself, do Metaglip, right? If you can get both of them together into one, that's going to be better for compliance. Think about that intelligent non-compliance. Why might they be taking it differently than what you actually recommended for them? Questions like that. And then, of course, can the patient actually physically take the medication? Can they inject themselves, or can they use the inhaler appropriately? Things like that. If a patient couldn't use an inhaler, what could I do instead? Yeah, you meant to think like a nebulizer. Is there an alternative form I can use that would be easier? So things to consider. Okay, so that's it for the geriatric stuff. So again, we always talk about geriatric patients kind of wherever we're talking about these drugs. So again, it's kind of a longitudinal sort of thing we talk about here. So any questions on that? I pretty much jive with what Professor Lack talked about for the most part. Good. Okay. So and again, just a little bit more specific stuff on prescription writing. Again, we've covered a lot of this before, but just to make sure everyone's on the same page. Remember, who can write prescriptions? PAs can. Yes, true. Not you specifically, right? You guys, you're still PASs. You got to get your C first, and then you can do it. Yes, PAs, mid-level practitioners, like nurse practitioners. Who else? Obviously, physicians, MDs, DOs. Yeah, vets can do it, certainly. So again, if I ever, again, vet, it's always interesting when you're like working at Walgreens and you see like, I don't know, Bingo Smith come in to get their cephalexin, and it's like the biggest dose I ever gave of cephalexin was like to the big old like Burmese mountain dog or something. It was just like basically gallons of the stuff. I was like, this seems like a really big dose for a person. And then I looked at it, I was like, oh, he's actually a dog, so that makes more sense. But optometrists, veterinarians. So again, it's important to know who can prescribe, who cannot prescribe. Make sure you can kind of what's valid and what's not. And these are specifically for drug purposes, not kind of referring back to durable medical equipment and other things. This is specifically just by prescriptions, that will be filled at a pharmacist or by a pharmacist at a pharmacy. So again, when you're dealing with state versus federal laws, which one do you follow? Whichever is stricter, right? So in general, you're going to follow whatever tends to be stricter. It may be state, maybe federal, just depends. Obviously, there's some exceptions to that if you were working somewhere where like medical marijuana was a thing, right? Because again, federally, marijuana is still a Schedule 1. So federally, still illegal to have marijuana. However, their state they're kind of ignoring that, and again, there's certain understanding there will be no kind of prosecution based on that. Yes, ma'am. That kind of makes sense. Yeah. So again, who knows? Who's to say that the DEA couldn't come in and say like, hey, we're gonna prosecute all these people for marijuana? But again, it's one of those points where it's like they wouldn't get a whole lot of benefit out of doing that sort of thing. So kind of, but in general, go with the more strict law. And if it's not addressed in state law, then just follow the federal one. Yes.
As the writer, I chose to go with the law that was less strict. Would the pharmacy deny it and go with the law that's more strict, or is that not possible?
It would depend on. I'm trying to think of a situation where that would occur, but yeah, in general, that would be if we were doing our due diligence and following whatever was truly strict, then yeah, we would give you a call and be like, hey, we can't do that, right? But in general, I think most general practice, like again, I don't know instinctively what is more strict, but you just kind of learn through practice, like what is the most common things you're done, and it's typically following, typically whatever is more strict in those cases. But like a lot of the controlled substance laws typically are more kind of federal based, but versus like specifics of like what needs to be on a prescription, you'll find there's actually Florida statutes. We'll talk about those in just a few seconds here. But looking at the Florida statute, so you can look it up yourself if you're ever so inclined, or if you need help getting to sleep or something like that, you can read through these. But notice there's different laws based on if it's a controlled substance versus a non-controlled substance. So in general, and you guys have been practicing this already, so I'm not going to kind of belabor this point here, but you need to have things like, it has to be written or typed, it has to be legible. Again, sad we have to put that into law, but again, it needs to be legible. Most of you guys are pretty good at that. Some of you guys have fantastic handwriting, some not so much. That's okay. I have bad handwriting too. Obviously, the name of practitioner, the drug that's actually being prescribed here, the quantity of drug to dispense, which is very important. Directions needs to be dated. Big things to note here that it can be communicated electronically. That's okay. We can fax things over. We can transmit it electronically via the internet. We can do all sorts of things. That's totally okay. But once it gets to the pharmacy, it has to be reduced down to writing, right? And this actually came up, Dr. O was actually asking me this question, but when you say you call in a prescription to a pharmacy, who has to be the person that reduces that down to writing? Has to be a pharmacist, right? Cannot be the pharmacy tech, because again, if you were to transcribe that incorrectly, then the patient can get the wrong drug, right? They can get the wrong dose and get wrong all sorts of things. And so it's really important to make sure it's either the pharmacy intern, which is someone who's like in school going to be a pharmacist, or it's going to be the actual pharmacist themselves that actually does that. So just in case you're ever curious, that is what's happening when you call one of those in. And again, they're only going to be good for 1 year. So you can write for as many refills as you want to carry a patient out to the end of time. It's not going to work, right? So we will cap it off at 1 year, and which is why when you get that prescription bottle, it usually says 1 year from the date that the patient filled it. Okay. When dealing with multiple medications, for our purposes, I like to keep things separated, but you can't put multiple non-controlled substances together on the same script as long as it's easily legible. It's easy to tell, kind of which instruction are going with which drug, etc. However, you need to keep controlled substances separated from those. So again, you can have multiple, like say C3s or C4s together on a script, but C2s have to be by themselves, right? So again, in general, if you're writing controlled substance, just write them separate, just keep them on separate pages. That's going to be easiest for everyone involved, right? You won't have any issues from pharmacists who are like, well, why is this on the same page as this other one? It's just easier. And again, this would be a good looking prescription. Most of you guys are doing very excellent with the prescription assignment so far, so I'm very proud of that. You guys will be experts by the time you get out in rotations. However, you may see some other examples of kind of what these will look like. Sometimes if you're in a big practice with multiple providers, you can just kind of mark off who is actually doing the prescribing. A lot of this stuff may actually already be filled in, which can be kind of useful and kind of speed up the process there. And again, most of you guys how are most of you going to be writing your prescriptions when you actually get out there in the real world? Electronics. You don't ever have to write this out again. You're going to say, darn that Dr. Wood, why in the heck do you make me write all these out? I'll never have to do this in my entire life, but you'll hopefully be one of those things you're like, well, I guess I grew as a PA because of that. And then I'll shed a single tear because I'm so proud of you guys. Anyway, don't write prescriptions like this. Again, I'd probably dock you off pretty heavily if I couldn't read it and look like that, so don't do that. And again, some additional requirements for controlled substances. Notice this is a different law than it was for the non-controlled substances. Basically, all of the same requirements for the actual non-controlled substance. However, you need to include some additional stuff. So things like name and full address of the patient, or in some cases, the owner of the animal, if it's going to be. And when might you prescribe a controlled substance for an animal? Yeah, usually the biggest thing, or the most common thing I see is if we're doing phenitone for like a cat or dog or some kind of animal with a seizure condition, we will have phenobarbital be prescribed pretty commonly there. If it's an animal species, it has to be specified. Again, I don't know animal pharmacology as well as I do person pharmacology. So again, if you wrote down like an iguana, I'd be like, I guess that looks okay, but the vet wrote it, so I'll probably put it through. I don't know, I mean, to me, iguanas have seizures, if you could even tell, but anyway. Get the full name and the address of the prescriber, right? And then you have to have that DEA number is going to be super important as well. So again, you may be able to get your own DEA number, or you may be working under the DEA of, say, the institution you're working at. It just depends on what your setup's going to be. And remember, this is where you need to have the written and the numerical quantity to dispense, right? This is where you actually have to write out the number 1, but then you write in parentheses 1, ONE, to make sure that they you cannot mix that up. Because what would be the problem if you wrote for, say, 10 milligrams of morphine? What could the patient do? Just add a little 0 on there, and boom, you got 100 milligrams of morphine. Great. By writing out 10, that makes it very obvious what the actual dose should be. You worry about it's less worry about the patient, altering the prescription, I should say. So for Schedule 2 substances, again, these need either be written or typed. There is no electronic or verbal communication of these. So you cannot fax these over. You cannot call these in for a C2. You have to actually have the patient bring a prescription in on paper. So that's one of the big differences between these and, say, other non-controlled or other controlled substances. And again, no refills for these. Right? You can write it for a 90-day supply. You can write for multiple scripts for up to 3 months, but you cannot do any more than that. Okay. And again, they have to be hand signed by the provider. We don't do like stamps or electronic signatures or anything like that. They need to be hand signed. Again, 3 through 5s. How long can those be good for? The prescriptions? Up to 6 months, right? So you'd write refills for up to 6 months. That's one of the big differences between that and non-controlled prescriptions. And those can be communicated by phone or by fax, whatever communication it happens to be. Now, when do we use counterfeit paper? What's the point of this? So, like, if you were to photocopy this, you see void all over it.
So you can't be like Catch Me If You Can.
Yes, you can be like the Leonardo DiCaprio movie biopic, Catch Me If You Can.
It's a true story.
That was a true story. I watched that when I was dealing with Phoebe when she was very, very little. I had many sleepless nights. I was on the Netflix binge. Anywho. But yeah, so if you were to make a copy of this, it comes up with void all over it, so that way the patient can't, kind of make 100 copies of the Percocet prescription, take it to every different pharmacy out there, right? That's a big thing there. That's very important. And again, a lot of these papers, they have to come from licensed manufacturers, and there's usually a number associated with them, so you can actually track them back. So I know that this hospital got this run of prescription pads with these numbers on it, and I can keep better control of that sort of thing. So again, C2s are very, very tightly managed versus other non-controlled or C3s through 5s. What about prescriptions for C1s? Can't do it, right? Because again, there's no medical use for those. Yep, absolutely. And then remember, just avoid unapproved abbreviations. So I've already kind of caught some of you guys on that. What's the big one you never want to use? QD, right? Daily, Q-day, whatever you got to do. QD is no good. IU, I know some of my advisees I've caught on this, but if you write IU, what can that potentially look like? Yeah, it could actually look like IV. So again, if you just write out units, you don't have to write international units. That takes too long. Just write out units, and you're going to be good from that standpoint. But again, make sure kind of use approved abbreviations. Every facility will be a little bit different. Okay, so make sure you're including strength and dosage form. Write in actual mLs. Don't write teaspoon or tablespoon, because again, an IKEA tablespoon might be a little bit different than the Walmart tablespoon. Make sure you're getting doses very accurate. And then no trailing zeros, no leading zeros, right? Or always use leading zeros, and avoid trailing zeros. Okay. Let's see. Include the quantity. Make sure it's actually appropriate based on what you're prescribing. And then in general, if you write say you write a brand name drug, so say you wrote Lortab on a prescription, is the pharmacy going to use the brand name Lortab? Yeah, so we have the ability by law to switch out for the generic. And why do we do that? Generally cheaper, right? Generally it's going to be cheaper for the patient. So again, we are kind of acting in the patient's best interest in that case. So we do that. However, if you want to make sure that we do not substitute that, you're right, dispense is written. Okay, so DAW, you can abbreviate that as DAW, and that way we actually have to write, or have to fill it with the brand name. We might have it on hand, we have to order it, but that is how you get around that. Okay.
So what's the point of that if they're equivalent?
If the patient maybe really has a feeling that like the brands work better for them, or maybe if there's like an inactive ingredient that they don't agree with that's on the generic formulation, it's not used very often, very infrequently, and there's actually some drugs you cannot substitute based on their there's what we call a negative formulary. Again, it's kind of beyond our scope here, but there's a negative formula drugs you cannot substitute because of the bioequivalence is not there, right? Remember way back in pharmacodynamics, we talked about bioequivalence, how two drugs have to show they get the same levels in the body, generic does. Anyway, there's an orange book, there's all kinds of stuff. Anyway, if we cannot show bioavailability, it is going to be the same between the two, and they're not bioequivalent, then you cannot substitute them, right? But before a generic comes out in the market, they have to show they're bioequivalent in order to, and again, that goes for probably 95% of drugs out there. Like a Synthroid is a very common one that you cannot substitute. If you write for Synthroid, we typically do not fill that with the generic form, mainly because of the fact that your T3 and T4 levels can differ between the different formulations, and so that was on the negative formula list for a good long time. Okay, make sure to try to include indications when you can. It really helps to clarify things a little bit. I actually ran into another PCA issue. Remember what PCA stand for? Yeah, patient-controlled analgesia. So remember, that's where we usually do like morphine or hydromorphone pumps where a patient can actually hit it themselves. I had another issue here where one of the anesthesiologists wrote for the patient was coming out of surgery. I think they had some kind of spinal surgery being done. Those are typically pretty painful. So they wrote for a Dilaudid or hydromorphone PCA. Patient had a bolus dose they can give themselves. They had a basal rate that was going consistently per hour, right? Because remember that helps with kind of the basal pain. Patient give themselves a dose for breakthrough pain. And then the doc had written for another one that was a Q2 hour PRN dose of Dilaudid the nurse could administer and just a PRN pain. So what do you think is kind of the issue with that? Right, so the nurse is having to decide just based on only PRN indication they have is, okay, patient's having pain. So if they're having pain, then I'm going to go ahead and give that dose, right? Not super appropriate because, again, what could happen? Patient keeps giving themselves doses, and the nurse is giving the dose on top of that, right? So again, if they don't communicate appropriately, they have dose stacking that can occur. Patient goes apneic, needs naloxone to reverse that, right? So what I had to do is call up the doc and say, hey, we need some kind of clarifier on here. He said, okay, well, write, PRN for the outside one, that's Q2 hours, like write PRN if pain uncontrolled by PCA. And that at least gives the nurse better direction. She's not practicing independently and can say, okay, the patient is maxed out on their PCA. They can't receive any more for this 4 hours. I can go ahead and give them an extra dose. Okay.
Is there like a maximum amount that the nurse can give in addition to the max dose, like within a certain time frame?
It's just every 2 hours as needed. So every 2 hours she can go in there and give that dose. So she's going to have to document that, but you can't give any more frequently than that. But certainly if the patient didn't need it every 2 hours, it might be every 6 or maybe whenever they actually need it. So again, be very specific, helps with these indications, make sure that everyone's kind of on the same page, right? And then how to keep pharmacists from calling you, because again, we're annoying. We will bother you. I had to call one provider yesterday probably 4 or 5 times, and I was like, I'm so sorry, I'm calling you again. And they're like, it's fine, it's fine. Very good orders. I won't have to call you. It's great. But anyway, make sure you look up the profile. Make sure there's no antagonistic combinations, right? So make sure one drug's not going to be directly counteracting another one. Make sure there's no duplicate therapies. That's a big one I have to call in a lot where, one provider will write for, orders for Zofran, and then another provider comes in and writes, again, similar orders for Zofran. We can't have both of them on there, right? Because then the patient can get too much, right? Allergy is another big one. Make sure things are legible, obviously. And then, obviously, right within your scope of practice. So if you are working at a dermatologist's office, should you be prescribing weight loss pills? Probably not, right? It's going to be raising some red flags. Or should you be writing for someone's Concerta at your derm office? Unlikely that it would be appropriate, right? So again, make sure you're keeping within your scope. Otherwise, you may get calls. Okay, any questions on that? All right, let's take a 10-minute break. We will come back and continue on.